but it's not only that. It's a man in advanced age. Actually, he's a nonagenarian who had a long history and significant cardiac comorbidities, which made the decision-making somewhat complex. So I'm not going to focus mainly on technical issues, but going to discuss this case in general. The index procedure was in 2002. He's a 91-year-old male, and in 2022 he was admitted with angina and in pulmonary edema, basically. His history started 20 years ago in 2005 when he had a myocardial infarction. He didn't do anything that time. And he presented again in 2017 when he had a PCI to his LAD and circumflex arteries. This was done by my dear friend and colleague Dimitris. You see here severely calcified coronary system with a very sort of significant lesion to his LAD and a long lesion to the obtuse marginal artery and the blocked right coronary artery. This was his X-ray, chest X-ray, which is normal, and this was his cardiac ultrasound at that time. And you see, there was some mitral regurgitation, not severe at the time, and there was a inferior basal wall abnormality, so it was classified as an ischemic mitral regurgitation, but nevertheless was not significant. The angioplasty required rotablator with a good result to the LAD and also a long stent to the obtuse marginal with a good result. And now he came back in 2022 when he was admitted with chest pain and pulmonary edema. Clinically, he had this time severe mitral regurgitation with a loud pansystolic murmur. So I had to do a transesophageal ultrasound and a coronary angio again to see what's going on. And I'm going to show you the transesophageal ultrasound. And you see there's a eccentric severe jet originating from the mid part of the mitral valve. And from first glimpse, it looked like ischemic, like functional mitral regurgitation, as it was associated with the basal inferior wall abnormalities. But on closer look, there was a flail part here. There was a rupture of chordae, and you will see that it was located in the anterior leaflet, as you see on the right side. So clearly there was an acute mitral regurgitation on top of a chronic ischemic. You see the flayed part here and the origin of the mitral regurgitation, which the tricuspid regurgitation was not severe, and the pulmonary artery systolic pressure was high at 65 millimeters of mercury. We did some measurements on the valve, and this valve looked suitable for TER. Plus his advanced age, of course, was not a surgical candidate. The jet of the mitral regurgitation was very broad, more than 1.5 centimeters, and the mitral valve area was measured at 3.6 centimeters. So all pointed out that it was a good candidate for a transcatheter repair, but we had to check his coronaries, of course, because he also had angina. And what we saw was a severe stenosis at the bifurcation of the left main stem, and the old stents were patent. So which procedure first? We had a discussion, and we decided to go on with a revascularization first in order to avoid any significant hemodynamic deterioration during the MitraClip. And that's what we did. This is the angioplasty, which was straightforward, much easier than the first one with the rotablator. And We followed the same session with the MitraClip. I'm going to show you a couple of pictures. This is the first clip, an XTW, one of the first XTW used in St. Luke's Hospital. And you see here the successive movement of the first clip. Obviously, there was not complete elimination of his mitral regurgitation with one clip. So we decided to implant a second clip medial next to the first one, a XT clip, in order to eliminate completely the mitral regurgitation and to stabilize the first clip. And this was the final result, which was quite good. He had some hemodynamic compromise during the procedure, but he was transferred stable in CCU, and he was discharged 2 days later in very good clinical condition. And since then, he's followed up annually, and I think it's interesting to see his follow-ups. In 2023, 1 year after the clip implantation, you see that the LV improved a bit, and there was some mild mitral regurgitation, as you see in the right picture. He was doing fine, minimal symptoms in 2023. He became a bit more symptomatic when I saw him a month ago in April 2025. His MR maybe got a bit more here, deteriorated a bit, and I think this is the contribution of the functional element. It's the sort of dysfunction of the left ventricle, which contributes to this mild deterioration. He became a bit more symptomatic, and his PA pressure now is 35 to 40 millimeters of mercury. So I don't think it's wise to draw any conclusions from a single case, but as a message, I would say that MitraClip for degenerative mitral regurgitation can produce excellent long-term results in advanced age population, even in the presence of significant comorbidities. Our patient is now 95 years old, and he still walks and he's up and about. And when combined therapies are necessary, I think it's wise to start with percutaneous revascularization first, and then follow with MitraClip. And this is in contrast with the other scenario of combined TAVI and PCI, in which case I think the TAVI should proceed, especially when there's a complex PCI to be done. And I think the choice of our sort of clips and gear is in line with the registries and what most people do internationally, where from this Expand G4 trial, for example, in most cases, the first clip in large anatomy is an XTW, and when there's a choice of a second or a third clip, then it's either of those 4 clips, or for a third clip, definitely it's sort of advisable to use a smaller device. So wide clips for the majority of cases as a first choice, and narrow and smaller clips as a second or third choice. And I'm sure there are some surgeons in the panel and in the room, so I would like to finish with a surgical perspective. And I'll play the devil's advocate for a moment. This is a study published this year, recently in January 2025. It comes from the United States Surgery and Transcatheter Intervention for Degenerative Mitral Regurgitation. And in this study, we included patients, total patients of in Medicare centers, and you see that there are 53,000 patients in total, and undergone either percutaneously repair or surgical replacement. And you see that as the years go by between 2012 and 2019, the TER numbers are going up, the surgical numbers are going down. But what they found is a surgical repair has better outcome at 3 years. I mean, this is expectable, I think, because we're talking about general population here and not high-risk cases, as the the one I showed. And the conclusion is that increased NTR utilization was associated with decreased surgical case volume, and randomized trials are needed to better inform treatment choice. Just some food for thought in the future. Thank you very much.
It was an excellent talk, so we're way behind schedule. So if there are any other comments from the audience, we should close the session with just a small comment that this was a very good example of LV remodeling after clip. This is something that we don't get to see that often, but this was excellent, Nikos. So thank you very much.